Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. And thank you all for joining us today, and our friends at El Rio in Arizona, who is hosting today's session. So today's session is Pediatric Voiding Dysfunction with Dr. Adrienne Carmack. She's the Director of Medical Affairs at BD, Becton Dickinson and Company, a large medical device manufacturer. She's a board-certified urologist with over 15 years of clinical experience. She's also trained in integrative, functional, and holistic medicine. Her passions include preventative medicine and patient empowerment. Dr. Carmack's areas of expertise include bladder and prostate cancer diagnosis and prevention, overactive bladder, pediatric voiding dysfunction, and other disorders of the kidneys. Dr. Carmack, it's great to have you here today, and I'll turn it over to you.
Thanks so much, Jill. So just briefly, the disclosure slide, I do work for BD, as Jill mentioned, but I won't be talking about anything related to any BD products today. The learning objectives today will be classifying the issues of voiding dysfunction in children, understanding common comorbidities, diagnostic criteria, and practical management, and determining when to refer. So briefly about me, as Jill mentioned, I'm a board certified urologist. I completed my training in 2007. And if you don't know, all urologists are trained in adult and pediatric urology, and there is an option to further specialize in pediatric urology, although that's more surgical, but adult and pediatrics is part of the scope of all urologists. I went to med school at Texas A&M, did my residency at the University of Miami, and currently I've been working for BD since 2020. As Director of Medical Affairs in the Medical Safety and Writing Department. And I maintain my urology experience by volunteering at a charitable clinic in my town. I go there one day a month and provide outpatient urology services to their patients. I live in Longview, which is a town in East Texas in the Piney Woods. And I am a mother of 3 children, and I've successfully navigated potty training with all of them. So that perhaps gives me more expertise on this topic than even being a urologist. So we're going to talk about a lot of things here today. The scope is pretty big, but we'll go into voiding dysfunction in children, what that means, what the definitions are in terms of both bladder and bowel dysfunction, lower urinary tract, bladder overactivity. We'll talk about enuresis and daytime incontinence, and we'll touch on the common comorbidities that are seen with voiding dysfunction and really focus on practical management and determining the red flags and when a referral is needed. So I'm going to start by just giving 2 very basic cases. The first one is a 6-year-old female, no significant past medical history, and she comes to you because she's having accidents at school. So I would love it if you guys would just start thinking about this and maybe type in the chat what differential diagnoses are coming to mind whenever you see this on your schedule and you know that this child's coming in to see you. And a second case, 11-year-old boy, similarly, no significant past medical history, and he's coming in to see you for bedwetting at least 4 nights a week. So think about what you're running through in your head whenever you see these 2 complaints on your schedule, what you're going to need to go through to help sort this out and how to help these children. I'm going to go through all the basics, and then we'll come back to these 2 cases at the end of the talk. So, and I can't see the chat. So if there's anything interesting in there, please let me know, Jill.
Yeah, I'll let you know. Thank you.
All right, great. Okay, so let's move on to terminology and definitions. So the terminology I chose to present here are from the International Children's Continence Society. These are pretty standard definitions, and there'll be maybe minor differences with other societies, but they're all pretty close. So bladder and bowel dysfunction is a single entity. It means the child is having both bladder and bowel disturbances. Lower urinary tract dysfunction refers to disturbances in urinary storage, emptying, or both. So a really important concept here is that the bladder has 2 main functions. One of them is filling and storage of urine, and another one is emptying. And you can have dysfunction in either or both of those areas. So normally the bladder should fill. You should be able to tolerate continued filling until you have a desire to void. Your bladder pressure should not go up until it's time for you to void. You decide to void, you should be able to, and empty, and then the cycle continues. Bowel dysfunction would be similarly a disturbance in storage or elimination of stool. And usually what we're going to see would be constipation or incontinence of stool, encopresis. So storage symptoms, it's actually pretty easy to tell by symptoms whether it's an issue of storage or emptying with the bladder. So urinary frequency is a common storage symptom. This is technically defined as voiding more than 8 times a day. Normal frequency is at least 3 times a day. So 3 to 8 times a day would be expected. Urinary incontinence is any involuntary leakage of urine, and this can be subclassified quite a bit. So continuous incontinence would be constant leakage, which could be due to a congenital malformation, such as an ectopic ureter, where the ureter exits the body directly or in the urethra distal to the external sphincter. And so as urine's produced, it just leaks out. Exstrophy variants would cause continuous incontinence. Any loss of sphincter function for example, neurologic reasons or iatrogenic reasons, for example, a vesicovaginal fistula, where the bladder's just draining into the vagina after a hysterectomy, would cause continuous leakage. Intermittent incontinence can be daytime or in uresis, and the definition is whether you're awake or asleep when it happens. Urgency is the sudden and unexpected experience of an immediate and compelling need to void. Like you've got to go right away, and it's not because you just drank 2 cups of coffee and have been sitting focused suddenly. There's sudden and unexpected. Urgency is a hallmark symptom of bladder overactivity, but it's not the disease overactivity. Overactive bladder is not just having urgency. Urgency can be caused by UTIs, it can be caused by stones, it can be caused by a variety of things. And so you have to rule out those other causes before you'd be making a diagnosis of overactive bladder. Nocturia is waking up at night to void, but it's not the same thing as incontinence or bedwetting. That's a separate issue. So nocturia, you actually get up and go to the bathroom versus having incontinence. And then emptying symptoms. So these are things that restrict urine flow and make it difficult to empty the bladder. So hesitancy is difficulty initiating voiding when you feel ready. Stranguria is having to strain to urinate. So like to do a Valsalva maneuver to get the bladder to empty. Intermittency refers to when the urinary stream stops and starts. This is a pretty common symptom in men with enlarged prostates, but you can see it in a variety of obstructive causes that children might experience as well. Weak stream, dysuria, burning or discomfort. When this occurs at the start of urination, it suggests that it's a source that's external to the urinary sphincter. When it happens at the end of urination, it suggests it's bladder or somewhere else proximal to the urinary sphincter. And then other symptoms. So holding maneuvers, this is something that is common in children. So these are behavioral strategies for them to postpone voiding or suppress the urge to urinate. So children may stand on their tiptoes, they might cross their legs really hard, they might grab or push on their genitals or the abdomen, or sit on the edge of a chair or use their foot to put pressure on the perineum. These are all defense mechanisms to help inhibit spinal signals to the bladder. And caregivers might not recognize that they're doing these to control urinary symptoms, but if you ask them about these specific behaviors, they might report them. And interestingly, when we train people train adults on managing overactive bladder, we will sometimes teach them how to use Kegel exercises to stop the urge. And so a lot of this is really kind of doing the same thing that children just naturally learn to do. Feeling of incomplete emptying. So that's when they urinate and they don't think they've emptied and they feel like they need to go back to the toilet. Urinary retention can be, again, the sensation that you can't urinate versus actually or just urinary retention not being able to at all. And whether this is acute or chronic is very important for management and diagnosis. Spraying and splitting of the urinary stream. This is when the stream isn't just a single discrete flow, and it's usually because of some mechanical obstruction either at or just inside the urinary meatus. And then genital pain. In girls, it can be pain or itching, and it's often localized irritation of the vulva from incontinence, or it can be irritation of the trigone of the bladder, which is the part that's in between where the ureters enter the bladder and where the urethra exits. It's a little trigone or triangle on the bottom of the bladder. And irritation there is actually pretty common, and we see it on cystoscopy a lot. It's just where the urine sits and rests, and the urine itself can be irritating. And constipation can also cause pain and itching in little girls. And then boys might have penile pain. They can even have episodic priapism if they're experiencing a full bladder or severe constipation. And they may have pain from urine trapping inside of a phimotic foreskin. And then micturition or post-voiding dribbling. This is when urine leaks involuntarily immediately after voiding. This is another common symptom seen in adult men with enlarged prostates, and it's basically urine gets trapped somewhere in the urethra, or in little girls it can reflux into the vagina, somewhere distal to the sphincter. Urine gets trapped there, and then it just freely flows after voiding, usually with standing up and moving around. It could also be caused by bladder neck dysfunction. This is an example of a syringocele, just to show. So this is the side view of the bladder. This is the prostate here, and the external urinary sphincter is right here at this portion of the prostate. So if a boy has a dilated Cowper's gland here, urine can trap in there, and then once he stands up and moves, the urine's just going to leak out without any control over it. So evaluation. So as with everything, history is key here. You really want to ask a lot of very specific questions so you can characterize the child's symptoms. You want to know about their potty training history, when they potty trained, if they had any difficulties, or if they ever potty trained. You want to know if their symptoms are associated with school or daycare or other environments versus not happening at home. You ask about all of these specific details that I mentioned, like whether they're actually having urgency, whether they're actually having incontinence, what their stream is like. And if you're not able to get a clear picture, then a voiding diary is a very good tool. And I'll talk about that a little more specifically on the next slide. It's also really critical that you know and look for red flags on the history. A lot of voiding dysfunction is not a problem, and it's something that just needs to be managed. It's a real opportunity to help children improve their body awareness and live healthy lives forever. But you don't want to miss the red flags when there truly is something anatomic or physiologic going on that they need help with. And you also want to use it as an opportunity to screen for comorbidities and social stressors, and we'll talk about those a little bit more later on as well. So voiding diaries, you can find a variety of these online. You can make up your own. It can be something very simple, like just marking down which nights of the week they wet the bed, or it can be super detailed where they measure everything they drink and every drop of urine that comes out. And you can do calculations on this to determine their bladder capacity and things like that. You really just want to capture whatever details are of interest to you for what you think might help this patient. If you feel like they're over consuming fluids, then capturing fluid intake might be helpful. If they're just seeing you for enuresis, you probably just want to know when they're wetting at night. If you're worried that they might have a functional bladder issue and you need to know their bladder capacity, then you'll want the details needed to calculate that. So the correct way to do this is you should do a full 24 hours, and you should start after the first morning void. So the bladder will contain whatever urine was produced over however many hours. You empty it, don't count that. Then you record all of the urine, and when you hit that 24-hour mark, you empty again, even if you don't feel like you need to, and that will tell you your urine output accurately. You want to do it for at least 2 days. They don't have to be consecutive. You can have them do it for as long as a week. And these are just a couple of examples I pulled offline about the types of, like this example here is when you're wondering why someone's leaking, and this tells you if they're just having stress or urge or mixed incontinence. And this one is a more detailed, helping you calculate bladder capacity and things like that. Bowel function is something that I always included on a voiding diary. So I would share the Bristol stool scale with patients and ask them to just write down whenever they had a bowel movement and which Bristol type it was. A lot of people don't recognize that they have constipation, and their rectum will be chronically distended, and that really affects bladder function, and they don't realize it. And it's amazing how often treating constipation will help improve bladder function. So I always educate my patients normal is 1 to 3 snake-like bowel movements a day, this Bristol type 4. And this can help give guidance on whether you might need Miralax or a dietary change or more time for bowel movements in the day, or whether punishment, could be a factor, because it does tend to cause holding and retaining of stool, which is not healthy. It also helps you recognize if there is any stool incontinence, and that should be an immediate GI referral. That's not something that should be happening, and they do require specialist evaluation for that. And then diet. It's so valuable to ask questions about this. Diet affects our urination more than anything. I ask about what beverages they are drinking. Usually there's not that many. Lemonade, soda, juice, all of those can be big bladder irritants. You also want to ask about how much they're drinking. I will ask if there's a food that the child's loving or consuming frequently. And if they aren't really giving me an answer, I might show them a list of common bladder irritants. A lot of these lists are available online from many hospitals, and they can tell me if there's something that the child's consuming a lot. If something is suspected as the culprit, it's very easy to just strictly eliminate those for 2 weeks and see how the bladder does. And you can do before and after voiding diaries, or just have them pay attention. I had a child once who was 2 or 3 years old, and she was having a lot of urinary symptoms. She was starting to have accidents, and she was also having diarrhea. And I asked about her diet, and her family told me that she loved eating super spicy salsa. And she would just eat a ton of it, more than anyone else in the family could eat. And I was like, well, why don't we try cutting that out? Because her body, it seems like her body doesn't want something that she's putting into it. And it completely resolved the issue from her just stopping that and breaking that habit. Physical and sexual abuse. So these always need to be considered in your mind as a possibility in cases of bowel and bladder dysfunction or recurrent UTIs. You can simply ask the parents if they're aware of or concerned that the child could have experienced any form of abuse. You can, based on the child's age, observe them or ask them. And importantly, make sure that they know that they can tell you if there are any concerns, that if this is a contributor. And of course, if you do receive any information suggesting that there is abuse going on, you have to report it based on whatever the rules are in your area. In Texas, it would require a call to CPS just for any suspicion. Physical exam, it's super important if a child's seeing you for the first time for urinary or bowel issues that you do a genital exam, or if their condition changes. It doesn't need to be an invasive exam. It just needs to be external. It can mostly be visual. If you really can't see the urinary meatus, you can do very gentle retraction of the labia or foreskin, never forcibly retracting it, just so you can see the meatus and make sure that it appears patent and in the correct position. But this exam just lets you briefly look for any anatomic abnormalities. It lets you check the meatus, it lets you see if there's a rash, lets you see if there's any signs of trauma. You want to check the lower back for sacral dimples, hair tufts, skin pigmentation, anything that might suggest a lower spinal cord injury that might be occult. You would want to consider checking the flank for CBA tenderness, which is pretty common in pyelonephritis, but you could see it in other congenital conditions where there's significant hydronephrosis, for example. And check the abdomen, especially for fullness or constipation, and to see if they have any suprapubic tenderness. Labs and imaging. So a urinalysis is a must. You should always be checking a urinalysis with any urinary symptoms. This can help you look for diabetes mellitus or insipidus, blood in the urine, protein, and any signs of infection. If there's any suspicion of UTI, it's pretty critical to get a urine culture. That's the only way to diagnose one, and it's extremely important for antibiotic stewardship to have a correct diagnosis and antibiotic sensitivities. Pelvic ultrasounds can be helpful. They are not warranted in all children with voiding dysfunctions. But if you have a suspicion for some reason of an underlying issue, then you can request a bladder volume. You can get a post-void residual, which is they have the child urinate and then see how well they're emptying their bladder. They'll be able to evaluate for bladder wall thickness, any dilation of the ureters, any kidney abnormalities. If they go up to the include the abdomen as well, they can also notice constipation and rectal dilation. VCUGs are really only indicated in children who have had febrile UTIs. Lasix renogram is used for children who've had UTIs, recurrent UTIs, to assess for kidney damage and help make surgical decisions. KUBs can be great if you suspect constipation. They actually show stool extremely well, and it's really easy to show it to children in a family and show them that their stool backed up all the way around and that it's putting pressure on their bladder, and that they when you combine that with the Bristol stool scale and show them, you're having bowel movements, but they're type 1 or type 2, you're just backed up and you've got to clear things out so there's room for your bladder to function properly. That can be a really useful tool. And then there's urologic tests that we can do in a urologist office. We can do a non-invasive uroflow where they just sit on a special toilet and it measures the pressures, and we can see dysfunctional voiding patterns. And we can do invasive urodynamics where we put catheters in the bladder and the rectum, and we can actually see the bladder pressures. We can do this with or without video, which is basically like doing a VCUG, so we can see any functional issues. And those are all options when a child's having more significant issues that need further workup. So diagnoses, so differential diagnoses for children who are having daytime symptoms. Overactive bladder, as we mentioned before, it's characterized by urgency, but it's without a urinary tract infection or some other pathology. So it's not urgency caused by another issue. They often will have frequency. They'll often also have nocturia, and they may or may not have incontinence. We would typically call this wet incontinence, or I'm sorry, wet overactive bladder or dry OAB, depending on whether or not they're also leaking. Voiding postponement. This is a super common in children. It's common in school teachers. It's common in people who have, high time demand jobs that don't take time to use the restroom. So it's habitual postponement of voiding using holding maneuvers. And there's a whole variety of reasons why people might do that. Underactive bladder is characterized by a weak detrusor muscle. And so there's a need to raise intra-abdominal pressure in order to start or maintain or complete voiding. They would typically have a weak urine stream. This is something that we would diagnose probably with urodynamics. Dysfunctional voiding is a habitual contraction of the sphincter or pelvic floor during voiding. So this is often a learned behavior, and basically they're just not relaxing those muscles that are under voluntary control when voiding. And so the bladder pressure will rise to overcome that. They'll have an abnormal voiding pattern. They won't empty all the way. And this leads to a variety of voiding symptoms and is typically addressed with behavioral modification. Stress incontinence is specifically leaking urine due to increases in intra-abdominal pressure, such as sneezing or coughing. Vaginal reflux is something that seems not uncommonly in young girls. So the urine will collect in the vagina when they're voiding. And then rather than going into the toilet, and then when the child stands up, that urine will leak out. The important thing with this is they would not have any other associated symptoms, and they wouldn't have nighttime incontinence. It's only after voiding when they're experiencing the symptom. Giggle incontinence is when there's leakage during or after laughing. And again, they would have normal bladder function the rest of the time. And then there's a condition called extraordinary daytime only urinary frequency. So daytime only, no nocturia. They'll usually void very small volumes, less than half of their estimated bladder capacity. And we estimate this based on its age +2 in ounces. So a 5-year-old would have approximately a 7-ounce capacity bladder. They wouldn't be expected to have incontinence. And in this case, what you'd really want to consider is whether they had polydipsia, diabetes mellitus or insipidus, a UTI. Viral syndromes could cause this, and we don't really have good testing for those yet, but it's often self-limited. And then for differential diagnoses for enuresis, so this is officially defined as incontinence during sleep in any child older than 5. Primary enuresis means they were never dry before for at least 6 months, and secondary means they were dry for at least 6 months, and now they've started having accidents again. It can be caused by polyuria, which can be due to excessive fluid intake, but can also be a physiologic polyuria because their vasopressin release at nighttime has not yet matured. So this is something that we partially understand. We also see it in pregnant women and in the elderly, where vasopressin release just isn't developed until a certain point, and then it can go away during those other conditions. This is often hereditary, so you can really get a lot of information from family history on these children. It's actually super common for another family member or sibling to be affected. And sometimes it's even an uncle or an aunt. It doesn't always follow the patterns you'd expect, although supposedly it is typically autosomal dominant. And definitely the age of resolution is very often quite similar across generations. There are also arousal disorders that are thought to cause enuresis. So it's pretty common for parents to say when they bring a child in for bedwetting that they cannot wake them up no matter what. Like they could pick them up, try to walk them around, and they won't wake up. It can be associated with obstructive sleep apnea, but that's not the only situation where we see this. And then some kids can just have nocturnal detrusor overactivity, where at nighttime they just have reduced bladder capacity. Epidemiologically, it's twice as common in boys. 15 to 20% of children who are 4 to 6 are still having accidents at night. So it's super common, and this just gradually drops off over time. There's still some children who have primary enuresis as old as age 18. They often will have associated lower urinary tract symptoms like daytime frequency. The older they get, if it's not resolving, then they're more likely to have other dysfunctional voiding as well. And comorbidities. So UTI is a very common one. This could be because they have underlying anatomic causes that are also causing their other symptoms. It could be that they just have pure voiding dysfunction, and because they're not emptying their bladder well, they're more prone to UTIs. It's very much sometimes a chicken and the egg thing to try to figure out which it is. Vesicoureteral reflux. So primary is when the ureter does not tunnel properly in the bladder. It just develops that way. And that's something that sometimes children will outgrow, and sometimes we do surgery to correct. Secondary reflux is due to voiding dysfunction. So this is something you might see in a child with spina bifida that hasn't been managed well. So if their bladder is chronically distended, eventually that pressure will flow up through the ureters back up to the kidneys. And then neuropsychiatric associations. So these are actually extraordinarily common. So 20 to 30% of children with nocturnal enuresis have a neuropsychiatric diagnosis. Up to 40% of those with daytime incontinence do, and up to half of those with fecal incontinence. So I'm curious for you all just to think for a moment about what you think might be the most common neuropsychiatric diagnosis that's associated with urinary or bowel symptoms. And if anyone wishes to type in the chat, that would be great. And I'll go ahead now. So the most common actually is ADHD. Others that we see, oppositional defiant disorder and just classic anxiety and depression. What's interesting is that sometimes treating the underlying condition will improve the bowel and bladder function. So putting a child on appropriate treatment for ADHD, and that child also has urinary issues, those urinary issues may actually get better with the appropriate ADHD treatment. And we're not sure why this is. There are some studies that suggest that similar brain regions control the neuropsychiatric manifestations and voiding function. And then another extremely common comorbidity is bowel dysfunction. This is why I always include the Bristol stool scale whenever I do a voiding diary. It's constipation is extremely common, and it's partly because of anatomic. As I mentioned before, if the bowel is full, it puts pressure on the bladder, and the bladder just cannot distend properly. Many cystoscopies that I've done, if a patient is constipated, I'll actually see a bulge in the bladder from the sigmoid, and it just prevents the bladder from filling normally and having the normal shape, and that affects the muscular function and affects emptying. And then it's also the same physiologic pathways, the same nervous pathways tend to control both the bowel and the bladder. So if you're insulting one, whether it's a drug side effect or something like that, it's very likely to also insult the other. And it's actually a tool I commonly would use when I would see patients with urinary retention. A lot of drugs might not have that listed as a side effect, but if they have constipation listed, then it's also very likely they would cause urinary retention, and it might warrant a trial off of that medication to see if it helps with those symptoms. And then neurologic. So spina bifida, obviously overt spina bifida impacts the bowel and bladder, but there's also spina bifida occulta, which is why I mentioned earlier, always checking the back and the sacrum. Of course, spinal cord injuries, tethered cord. If there's any suspicion based on, if they're having bowel and bladder dysfunction and they've got a dimple on their sacrum, then you'd want to consider a spinal MRI, or we could do urodynamics in the urology office to see if there's evidence of neurologic firing issues with the detrusor muscle. And then acquired conditions can also cause this, like transverse myelitis or multiple sclerosis. And you consider diagnoses such as these, of course, if they had other symptoms such as muscle weakness or other neurologic manifestations. So treatment, primary here is education. Most of these voiding issues there's not going to be a red flag present. The physical exam is going to be normal. And so it's super important to help parents understand what might be causing this, and that it's rarely behavioral. So for example, if a child's having enuresis, explaining to them about they haven't developed ADH at night yet. They're not intentionally wetting the bed. They are making more urine at night than you do, and and they're sleeping deeply and they're not noticing it. So really discouraging punishment. Punishment only makes this worse. It induces a fear response. It's impossible to relax and empty the bowels or bladder, but it is so common. I mean, I've seen parents after parents who think that it's a behavioral thing and they need to punish it out of their child. And I do everything I can to discourage that. But instead, what's good is to help make it as simple as possible to manage accidents when the child has one. You can give the child a fair amount of responsibility, not as punishment, but you can set things up so that it's easy for them to change their sheets. You can get a waterproof mattress cover so it's not destroying the mattress every time they have an accident. And then also educating the child, helping them see that even if they don't feel like they need to urinate, their bladder is constantly filling. And if they would go at opportune times, like during breaks or before car trips, then they can avoid having that urgency and not having time to manage it. I think all of us who are parents have told our parents before we get in the car to try to go, and they say, I don't have to go. But I would encourage them. I'd say, go anyways. Then I'd be like, see, you really did have something in your bladder. You were able to empty it, and now you have more time for a longer car ride. And then also helping them associate the intake of certain fluids and foods with urgency. And elimination diets can be a huge help in directly demonstrating that, both to children and adults. I've seen adult women with overactive bladder who are going to be prescribed medications that have black box warnings for dementia who were drinking Pepsi 3 times a day. And once they cut Pepsi out, their symptoms were totally gone. And just demonstrating that to a person really helps. One of my children, if she drank lemonade, she would have such severe urgency 30, 45 minutes later. And so we learned that if she was going to drink that, it needed to not be right before we got in the car when she wouldn't have time to get to a bathroom. And then also education about normal bowel movements, and the Bristol stool scales are by far the best way to illustrate that, to show people what's normal, to explain to them that they need to take the time to be able to eliminate properly, and also to tell kids what they need to tell their parents about. If they're having type 1 bowel movements, that's something that does need to be addressed, and that they should bring to their parents' attention. So urotherapy is another strategy. So timed voiding is actually really great. This is something that you can do with a schedule or with watches and alarms. This is a screenshot from a website that sells things like this. So these timed voiding watches here in the middle, they basically have a vibratory alert every couple of hours to tell the child to go use the restroom. Working with schools is super important. And what I would encourage teachers to do was to prompt the child to use the restroom during appropriate breaks and things. But if the child came in the middle of class, to never say no. And obviously it can be manipulated for behavioral reasons. And so that's why you'd want them to try to work with them at other times. But again, it's a common issue where I saw children who would have accidents because they weren't allowed to go when they needed to go. And these kids just really didn't have the awareness yet to go at the right times. And it just made everything much more difficult. So I've plenty of times written on a prescription pad, please allow the child to void whenever they ask. Please encourage them to go void every 1 to 2 hours. And I've seen a lot of teachers be very responsive to that. For bedwetting, there's bedwetting alarms, which I'm sure some of you have heard of. These are basically devices that clip on the underwear, and when they get wet, they make an alarm that's supposed to wake the child up. So they're after the fact, but helps at least clean up faster and maybe alerts them before they finish voiding so they can get up and finish in the toilet. These, I've had some people have success with these. A lot of children just sleep through them. They're about $100. And so it's kind of a family decision whether it's worth it to try it. Because if it does help, it's great. But if it doesn't, then that's $100. And then several other types of behavioral modifications that help. So double voiding is when you urinate and then 5 minutes later urinate again. This is really good for people who have reduced sensation in the bladder or who have trouble emptying all the way. Or if the bladder gets over distended, it can be harder for it to contract to completion. So this can help get it all the way empty so that you're not having to go back again in 30 minutes. Toileting position and awareness of this is especially in little girls. The normal adult-sized toilets put small girls in a completely horrible position for urinating. This is why we see things like vaginal reflux or incomplete emptying. And then encouraging relaxation during voiding and stooling. These are parasympathetic activities. And if you're stressed out and you're rushed, you're not going to empty completely. And your body's never going to get into that state where it needs to, where it can empty and rebalance. And then using voiding diaries for self-awareness and informing care providers, those are invaluable in both children and adults, really. And paying attention to bowel function, as we mentioned, treating constipation, either with increased fluid intake, water specifically, or supplements such as magnesium or Miralax in whatever is needed, dietary changes, etc. And then you can also, we have more specialized care. So there are physical therapists who specialize in pelvic floor muscle rehabilitation. There are options for neuromodulation, which we use more often in adults, but sometimes in children. We can do biofeedback, and they've actually, pediatric urology centers will have these special biofeedback machines where they basically put a sensor on the perineum that'll detect when the pelvic floor is contracting, or they'll have the child measuring their urinary flow rate and showing them when they're urinating whether or not their pelvic floor muscles are relaxed like they should be, and they've been gamified into where they can progress across the screen, and whenever their pelvic floor relaxes, they're able to advance forward in the game. And then medications. So most of these are off-label for pediatric use. I'll mention the few that are on label here. For storage issues, mostly for overactive bladder, you can use anticholinergics, and there are actually 3 that are FDA approved for children over 2. And then mirabegron is also approved for children over 3. These are mostly used in children with spinal bifida or spinal cord injuries, because those tend to cause bladder hyperactivity. And we know that if we mitigate that with the anticholinergics, then it decreases the chance of renal involvement later due to the back pressure. It would be pretty rare to use these in a child with normal neurologic function. So this is something that would be prescribed by a urologist only. We can also use Botox injections. Those are used pretty commonly in adults for overactive bladder, and we do use it sometimes in children who have hyperactive bladders for neurologic reasons as well. Emptying issues, so bladder neck dysfunction. This is something that's diagnosed with urodynamics, and sometimes alpha blockers might help. This is another one that you wouldn't be able to diagnose this just by history and physical. You would need urodynamics, and so a urologist would have to decide on this one. And then nocturnal enuresis, desmopressin, and imipramine are both options that you can use, and I'll talk a bit more about desmopressin later on. And then things like SSRIs or ADHD medications. These, you wouldn't use these specifically to treat a bowel or bladder issue, but if a child has an appropriate diagnosis for those, it might help their urinary symptoms by treating the psychiatric, the neuropsychiatric issues. So red flags, I've talked about a lot of things that you would look for. And so I'd be really curious if, again, if people would be willing to type in the chat what red flags they think, what things they think they would find on physical or on history that would require them to send the child for a referral, or to suspect that this is something more than primary enuresis that's just hereditary and expected to resolve, or other voiding dysfunction issues. I'll just wait a few seconds and then I'll go on to my list. Okay, so these are the ones. There are more than this, but these are the ones that that I think I've covered here. So any history of febrile UTIs, that is a sign of possible vesicoureteral reflux. It should be evaluated further by a urologist. Any secondary incontinence or enuresis, so if a child was completely potty trained for more than 6 months and then starts having issues, that's much more likely to be a problem that requires additional treatment than primary incontinence or enuresis, where they just never did get complete control. Inability to potty train at all. So this is more likely to be overflow or continuous incontinence, where they just can't. It's not that they potty train some, but they still have accidents at night. Sometimes this is they have never been able to maintain control of their bladder at an appropriate age. Physical exam abnormalities, like some of the ones I talked about, like sacral dimple or meatal stenosis. Of course, any evidence of sexual abuse on the history of physical exam. If they have any history whatsoever of urinary issues, so if they've had spinal cord issues, if they've had surgery, if they've had any congenital malformations, then there's a very high chance that there's something affecting their bladder as well. And as I mentioned earlier, any fecal incontinence, they should be sent for gastroenterology referral. So back to the cases. The first child that I presented, 6-year-old female, no past medical history, and she's having accidents at school. So this one, the history is extremely important here, because that's not enough information, obviously, to guide you at all. So we ask her all the questions. She has no red flags, no urologic surgical history, no febrile UTIs. She has a normal exam. She potty trained normally, and she was not having problems before school started. So when we ask more details, basically she's coming home with wet panties. At school, she's rushed to go to the bathroom during quick breaks. The toilets that they use at school are adult sized, and she's noticing accidents right after she pees. But at home, she's using a squatty potty because that's what they have at home, and she uses that to elevate her feet. So this is a pretty classic story for vaginal reflux. And you would never do a VCUG for this, but this is an example of what's going on here. So this is a frontal view of a voiding cystourethrogram, and this is a side view. So basically there's been a catheter put into the urethra and the bladder is filled with contrast. The child's urinated in this image. And so you see the bladder and the urethra with contrast, but you also see this contrast filling the vagina. And so there's no sphincter here. And whenever she stands up, this is going to leak out. This is actually really easily treated with voiding techniques. And this is extremely common. I mean, I probably saw this 20 times a year. When little girls sit on the big toilets, their feet hang and their bottom will sink into the toilet, which puts them at an angle where the urine naturally goes right over the vagina before it gets to the toilet and will fill like you see in these images. And then little girls often also they'll pull their pants or shorts just to their mid thigh, but then their legs are held together while they're urinating. So what you want to encourage is elevating the feet, using smaller toilets. They can even use like little baby Bjorn little potties and then just empty those afterwards. And then, or if they just need to use whatever toilet's available, you can instruct them to completely take one leg out of their clothes and to separate their legs when they sit on the toilet, which will make a huge difference. And a lot of urologists will tell them just to sit backwards on the toilet. And if they're in a place where that's socially acceptable, which school might not be, but that will keep the urine from getting trapped in the vagina, and it'll completely resolve this problem. And the second case is an 11-year-old boy, no past medical history, chief complaints bedwetting at least 4 nights a week. So he's never gone more than 2 weeks without having an accident at night. He did used to wet every single night, but over the past 3 years, it's decreased to about 4 nights a week. His father wet the bed until he was 13, and he has no history of UTIs and no genitourinary history other than a neonatal circumcision. So on physical exam, you actually notice that his meatus looks like this one on the right. So these are images of adult penises. This one has an intact foreskin, and you can see that the head of the glans penis is not keratinized because it's protected by the foreskin. And this is what a normal meatus should look like. This one, this is someone who's circumcised as a neonate, and so the glans keratinizes as a result of exposure, and meatal stenosis can happen where you can see the meatus is much narrower. This one is actually not the most severe. Sometimes it's literally like a pinpoint. Very common to see this in young boys around the age of potty training. There was actually a really good article published in Denmark where they collect all of the massive epidemiologic data, and they looked at 2 groups of men. One was a group of 4 million and one was of 810,000. And the hazard ratio for meatal stenosis was 26 times for those who'd had circumcision. So it's almost always seen in boys who are circumcised, and is a very common complication of that. And again, it often doesn't present until they're potty trained. So on further questioning this child, when you see this narrow meatus, he does admit that his urine stream does spray some, and he has to wipe the toilet after he goes. You refer him to urology. We would do most likely an in-office meatotomy. You can also do a needleplasty in the operating room, but you basically just numb it up and you can snip the meatus open, and it usually heals open just fine. On occasion, we can put a couple sutures in to facilitate the healing process. So after he has that, the spraying improves, but of course he still has enuresis, which is expected. The meatal stenosis can cause urinary symptoms like frequency, but it's not really going to cause enuresis. His case of enuresis sounds very much like physiologic, just not matured yet, not making ADH yet, genetic. So for him, the management now is anticipatory guidance. He is improving. The frequency of nighttime accidents has gotten better, and that's expected to continue. Knowing this is hereditary, he will outgrow it. There's no reason there's no red flags, reassuring the parents that we're not seeing anything that indicates there's an underlying abnormality, but he likely just inherited whatever had caused this in his father as well. Encouraging them to, as I mentioned earlier, making accidents easier to manage, restricting fluids at night, at least a couple of hours before bedtime. They could try bedwetting alarms if they wish. He certainly should try to empty his bladder before bed. And then we can offer desmopressin. So the challenge with this is that there are serious warnings with this drug because it completely blocks your ability to make urine. And so if you drink fluids while you're taking this, you're going to get diluted. So hyponatremia is common, seizures are common. So I would never prescribe it without really talking to the families about this in depth. If you do start it, you can use nasal spray or tablets, and the dose is 1 to 3 tablets or 1 to 3 sprays. I encourage them to start low, and every 3 days, if it's not working, go up from 1 to 2, etc., and finding their lowest possible effective dose. But then once they found that dose, only using it when they really need it, because it's much better to not take it regularly, to not take this risk of hyponatremia and seizures, and learn to manage the accidents, but to use it when it is creating, especially the older children get, the more likely that this is going to interfere with their social life, and more likely that there's value to using something like desmopressin. I would always offer it as an option. And honestly, a lot of my patients, when they heard about it, would say, no, we'll just keep waiting this out. It's not a big deal. We just wanted to make sure there was nothing more wrong. I encourage those who are really bothered by the enuresis for social reasons or whatever, figure out that effective dose. Don't take it all the time, not only because of the risk of hyponatremia, but also because this is going to get better over time. And so if you just go on this and stay on it for a year, it's possible over that year you may have gone down naturally to just having 1 accident a week, and you don't really know where you're at in that resolution process if you're taking the medication all the time.
Dr. Carmack,
Yes.
so right, you're right. So you're right at the end. What I think, I don't know if it's a calendar reminder is also showing on your screen, but
Oh,
it's actually
let's
okay
see.
if since you're at the very end, you could just stop share.
There we go. Yeah, got it. Thank you. Yeah, so that's a big overview of this. Any questions?
Great. Thank you so much. What a thorough and interesting presentation. I'll have you stop your share, and
Okay.
then wanted to invite any of the attendees, if you have any questions or even just sharing what are the types of cases that you see in your clinic. If you have any tips and tricks that you have found particularly helpful with your patients, we would love to hear from you. So I'm just going to wait a minute. You can either type in the chat, or if any of the attendees want to verbally talk out loud, just raise your hand and I can unmute you. So we'll just wait a minute here. And I can just share that my children were late to potty train, and found out that my husband was also late to potty train. And I didn't know that hereditary component.
Yeah, it's pretty impressive. It's almost 100%.
Mm-hmm.
The only times I've seen families not know is when they were adopted, or they were from families that are like, there's no way they would have told us. And so it was kept secret.
Yeah, exactly. Yeah, so if anybody has any questions that come up after the fact, you can email me or Kristen Talbot, and I can put my email address in and I can forward your questions to Dr. Carmack. So let me just put that in there. It's jeinstein@mavenproject.org. And just as a reminder for those of you that are claiming CME, you'll get as we close out of the talk, or you leave the talk, you'll get a link to completing the survey. And just remember that today's April 4th, that you use your correct email address that's associated with your MAVEN Project account. And Dr. Carmack is our speaker today. So thank you so much, Dr. Carmack, for this great talk and sharing all of your knowledge with us. Really appreciated. And a shout out to all of the providers for the amazing work that you do in the clinics, caring so well for your patients and wanting to learn more. So I hope everybody has a wonderful day.
Yeah, thanks everyone for your attention.